Dr. Molk and Dr. Shapiro. As seasoned emergency physicians, they wrote their book, Saving Lives, Saving Dignity, to give readers a unique end-of-life perspective, as they will explain in the next hour. Please join me in welcoming Dr. Molk and Dr. Shapiro.
Hello, everyone. I'm Dr. Alan Molk, and I know my cousin and co-author, Dr. Robert Shapiro. I did see his picture here today.
You don't?
There he is.
I'm here. Here I am.
I will be doing the PowerPoint presentation that I prepared. And at the end, Dr. Shapiro and I will both be open to questions and answers. And we have time. I'm also open and encourage some storytelling that anyone would like to share with us that is maybe relevant to what we've discussed today and what the subject matter is. So without further ado, I'm going to begin my PowerPoint presentation. Let me just share my screen here quickly.
Get this. There we go. Oh.
Does everyone see it or not yet?
Looks great.
Very good. Okay. So here we are. Today is the second month of the year, 18th of February. And I'm showing you here a cover of our book. This is the cover right here. This is the old book. We're into our second edition now. Our second edition was a #1 bestseller, recently re-edited, republished on Amazon. And hopefully some of you will be interested in looking at it, buying it. It's available both in soft cover, soon in hardcover, and also as on Kindle. So here we go. Why is my slide not moving? Give me 1 second here. I need to add one more thing here quickly. Oh, here we go. Okay. So a little introduction about myself, Alan Molk. I'm going to be talking largely about me. Dr. Shapiro is going to get sort of background billing. Let me tell you that I'm not your average ER doctor. By average, you'll know what I mean in a second. I'm the father of triplets, Usher, Ariel, and Eliza. The picture you see of them on the right side was when they were all three at the University of Arizona in Tucson. And I was taking them on a shopping spree to Costco, something I did with remarkable regularity. They always needed something, and I always would quickly scoot down to Tucson to take them shopping for whatever they needed. They are now grown and 30 years old.
Hi, Dad. I'm here.
And Eliza's there as well. This is Eliza's wedding on the left, and you may recognize the person in the middle. That is Rabbi Burke, your emeritus rabbi, who married Eliza and John in La Jolla. And that's me to the right of Eliza. Rabbi Burke happens to have a brother who is our emeritus rabbi here in Phoenix at Temple High. What a small world. And on the right, you see my wife, Laura. We call her the lawyer Laura. And that is an initial introduction to the family. I will tell you, I'm an avid Boston Red Sox fan and a Yankee hater. Some of you may be from the East Coast, and some of you may like or dislike what you see. The picture me on top is me at Fenway Park, and at the bottom, I'm in Manhattan in front of a Yankee store. I'm lucky no one threw some rocks at me. I also play the accordion. My cousin Bob Shapiro is an extremely accomplished pianist, and he pokes fun of my accordion skills. But what I do at Christmas time, I always work and I play Christmas carols on the accordion for all the co-workers. I also like to have fun. I believe in humor. I believe that humor is good for you, extremely therapeutic for you. And I often am portrayed as a guy who's a bit of a mishuggah. And I find that helps maintain my sanity. So I've always been viewed as the eternal optimist, the class clown when I was in medical school. I love to cheer people up. I love to laugh. So Those who know me still to this day cannot believe that I co-authored this book with Bob, covering a serious and important topic. So what prompted me to write this book? Well, and every time I start talking the book, I sometimes get a little choked up. Give me a second to regroup myself. My beloved mother, Serona, had Alzheimer's. She passed away 8 years ago. And I can tell you, I initially started writing this book when she was still alive as a catharsis to deal with her deteriorating condition and to deal with my own grief. Our journey with Alzheimer's. My mother was the most harmless, most upbeat person I ever knew. She was my role model in life. She was the most selfless person I ever knew. And she never wanted to be a burden on her family. But yet, her worst nightmare came true. A quick reminder, a sobering reminder that life as we know it on earth has a beginning, a middle, and an end. Many of us in the medical world as physicians still look at death as the ultimate enemy. We hate losing patients. But to many patients and their families, death actually comes as a friend. After a lingering illness comes accompanied by intense suffering, death often comes as a major relief to the surviving loved ones. I got a slide here of Dr. Christian Barnard, a South African heart surgeon who did the first heart transplant in 1967. His patient, by the way, was a Jewish guy named Louis Washkansky. And he himself stated that often, in spite of medical advances in technology, stopping the suffering of the patient when death takes over is a good thing. Not everybody, as we know, makes it to a ripe old age. I can tell you, and many of you have seen this as well, I recall visiting my mother's grave here in Phoenix, walked around the burial site, and I was stunned by how many of the people buried there didn't even make it to age 60. Here are a lot of famous examples. Jimi Hendrix, Marilyn Monroe, Jim Morrison, Eva Peron, J.F. Kennedy Jr., Buddy Holly, and Amy Winehouse. I'm going to tell you about a survey that was done of physicians. The survey was, where would you as doctors want to be at your end of life? Over 80% said, I want to be home surrounded by family and friends. Yet, we as physicians, we have this double standard going. Many of our patients who are end of life still end up and spend their last moments in the intensive care unit, receiving aggressive, heroic, yet care that is invariably futile, only prolonging the inevitable and endless suffering. This is a little excerpt from a book written by Moira Allen called Coping with Sorrow and the Loss of Your Pet. Talking about what we consider about the quality of life and dignity, and dogs too have dignity and quality of life. When we make a decision that their end is near, we look at their mobility, how they're eating, are they uncomfortable, are they becoming continent, do they seem confused, do they seem unhappy, are they not responding to treatment? And we make a loving decision. But yet, we don't really follow this very well with our own human loved ones. I'm going to come back to this later when we have time. And this is a real story of a friend of mine. His name isn't David, but we'll call him David, who regretted aggressive care that was rendered to his mother. And there are many, many, many others, stories that are similar. Many patients given the option of ongoing aggressive care, and what you see on the left is a gentleman on a dialysis machine, When given the option of ongoing aggressive care or going the option of less aggressive and more comfort care, and you see a picture of Barbara Bush in her last days, would choose B. Quick definition of what defines dignity. At that state or quality of being worthy of respect and honor. To me, it's comparable to quality of life. Of course, dignity and quality of life do mean different things to different people. What's an acceptable quality of life to me may not necessarily be an acceptable quality of life to you, and vice versa. How important is dignity? Well, in a large recent survey of physicians, the following question was posed. What single life-changing event would indicate that you have had a serious change in your dignity or a loss of dignity? Here's your answer. The inability to wipe yourself after a bowel movement. Think about that for a minute. And this in itself could be a game changer in decision-making at end of life. Sadly, so many life-limiting diseases and conditions strip us of our dignity. These are all self-evident. Alzheimer's, metastatic stage 4 cancer, end-stage congestive heart failure, end-stage emphysema or COPD, end-stage liver disease and cirrhosis, diabetes with multiple diabetic complications, many neurological conditions such as Lou Gehrig's or ALS, Parkinson's, multiple sclerosis, and many more. Talking about end-of-life care seems somewhat counterintuitive to someone like myself and Bob, who's also a board-certified emergency physician. Counterintuitive meaning contrary to intuition or common sense, but often nonetheless true. Because we as ear doctors, what do we love? We love an adrenaline rush. We love resuscitating and stabilizing. We love intubating, putting chest tubes and central lines. We love being diagnostic sleuths, and we love saving lives. What do we loathe? What do we dislike? A full waiting room that tells us there are patients who need to be seen, we need to take care of, we want to get them back and seen and treated. We loathe unsuccessful resuscitations when we lose a patient. We loathe being unable to fix something, or missing a diagnosis, or giving up. We reluctantly accept that many patients and their families often have limited medical knowledge, which makes our lives more challenging. A classical example is seeing a patient who has never seen us before, who is taking 10 different medications, and you'll be surprised they have no idea what those medications are. They'll say a red pill, a blue pill, a green pill, and a white capsule, and then we have to figure it out. Makes our lives more challenging, but that's the way it is in what we do. We also reluctantly accept that we cannot mend many of society's ills, many of which we deal with in the emergency room, dealing with unemployment, depression, domestic violence, homelessness, and drug and substance abuse. However, we are grateful and pride that we are the safety net of the medical world. We are open 24/7. We are always there to see people. We never turn anyone away. And daily we see patients who struggle with these issues that involve not just medical conditions, but also the ills of society. So how did I develop an interest and passion for what this book is about? End-of-life, dignified care, hospice care, palliative care. In addition to my mother's journey, the face of emergency medicine has changed over the years. The obesity and diabetes epidemic and the resulting complications of obesity and diabetes have drastically affected the type of patients we see these days. Patients have become sicker, disease processes way more complex, aging population, the baby boomers, and many patients with multiple comorbidities, meaning they don't just have one or two things wrong with them, they have 3, 4, 5, 6, 7, 8, and more wrong with them. And we are seeing more unintended consequences of medical science to prolong life. Yes, we've done a lot of things to cure many conditions, to prolong the lifespan, only to find that other things have now occurred that become new medical challenges. I have to admit, I feel, and so does Dr. Shapiro, that in many patients, too much is being done for too many patients with a poor quality of life for far too long. As a result, the loss of human dignity and worsening of quality of life ensues. So we began to realize that much of what we are in fact doing may in fact be morally wrong, maybe inhumane, maybe unkind, and may in fact not even constitute good care. I talk about the revolving door of the ER. On a daily basis, multiple times we see patients who are end of life who really don't belong in the emergency room, but would be much better served with hospice or palliative care and treated more appropriately and in a more dignified fashion. There are numerous real-life examples in our book, that illustrate this, and I'll make you feel the impact of this problem. I'll quickly go over 3 quick cases. These occurred in just a 2-hour period. A woman with multiple complaints. She's 70, but she looks 90. She's got multiple medical problems. She's got vascular disease. She's had breast cancer, diabetes, emphysema, aortic aneurysm, severe arthritis, anxiety and depression, severe coronary artery disease, and she lives alone. A man just 60, retired military, morbidly obese, fell on his side, injuring his rib cage. He's on a blood thinner. He's got atrial fibrillation. He feels like he broke a rib, which he did. He's had a previous stroke. He's had a pacemaker placed. He's had coronary disease with stents. He's got cardiomyopathy, congestive heart failure, also anxiety, depression. You would too. Severe arthritis, diabetes, sleep apnea. He's on dialysis. And now he's got broken ribs to add to his misery. And then we had the widowed 92-year-old man who was just discharged from the hospital 2 days ago with a revolving door, with pneumonia and congestive heart failure. He fell at home after being discharged. Luckily, no serious injuries, but he has memory loss, he has emphysema, he's on blood thinners, he's got an enlarged prostate, he's had urine infections, he's there with his family, who feel they can't adequately take care of him. They want to put him in a skilled nursing facility. The patient refuses and wants to continue independent living. You've all heard of similar cases. We see this every day in the ER. These type of patients have become much rarer. Were much rarer 30 years ago. Now they become the norm. We never really cure them. We really just band-aid them. Occasionally, these patients may have a new treatable minor condition that can be cured with surgery or an inpatient admission, like having their gallbladder taken out, for example. I can tell you, speaking of the obesity epidemic, I never cease to be amazed when I see a 300-pound plus patient and I ask that individual, do you have any other medical problems? And they respond by saying, oh no, I'm fine, I'm in great health. That is the new norm. I need to say something about the crystal ball epiphany that I think is important. I was visiting my mother a few months before she died. She was in a wheelchair. She couldn't speak anymore. She couldn't feed herself. She was incontinent. She was just staring into space. And suddenly something struck me. I called the crystal ball epiphany. I thought to myself, what if 6 years earlier, before she started the first signs of Alzheimer's, I went up to her and I said to her, Mom, I have here in my hand a crystal ball. This is what you're going to look like 6 years from now. What would she have said? And I can tell you exactly what she would have said. She would have said, oh no, please don't let that happen. Push me off a cliff if you have to. Incredibly, the last thing I recall my mother saying with tears in her eyes before her insight permanently disappeared was, Alan, I'm so sorry that I've become a burden on you. Now, there are certainly many situations where family and loved ones consider it an honor, a privilege, a duty, and a mitzvah to care for an aging parent or loved one. They don't consider it a burden. And this is wonderful and praiseworthy. Briefly talk about a concept I use a lot. I call it the professional patient. And at this point, your life and your job is to be a full-time patient. Something I can say for myself, I would never want that. I would never want to be a burden on my family. So how about you? Think about it. Talk a little bit about the baby boomers. I'm one of them. We need a reality check. Now, our numbers are rising. By 2030, healthcare for us is going to be, described by a healthcare expert, a daunting task. And we're talking just 9 years from now. Medicare dollars. Almost 30% of Medicare dollars is spent on the last 6 months of life. Think about that. Many of us are unhealthy and have let ourselves go. We are part of the diabetes and obesity clinic. Yet we want everything done and we feel like we deserve it. But do we in fact deserve everything, considering years and decades of self-destructive and unhealthy habits? Many healthcare experts note that we are going over the fiscal cliff due to an unsustainable, and I'm going to use that word unsustainable again, healthcare system. What are we leaving behind? A bankrupt system? Is that fair on the next generations? We need a healthy dose of reality. We owe it to the next generation to leave the word sustainable,
Okay, thank you.
including limited pollution, climate change, the ecology, and a sustainable healthcare system. Let's debunk some myths. You see the boogeyman looking in. Here's a myth. Doctors are gods. There's a good myth for you right there. No, we're not. We're human and mortal like everybody else. And as hard as we try, we cannot really reverse the aging process. There goes Bigfoot. Doctors can cure everything. Myth number 2. Yeah, we can cure strep throat, bladder infections. We can even cure TB and some cancers if detected early, but we cannot cure Alzheimer's or Lou Gehrig's or stage 4 cancer. Mostly what we do is called disease management. That is not healthcare. We can cure kidney failure, but we've got dialysis. We cannot cure coronary disease, but we have stents and bypass. We cannot cure strokes, but we have clot busters. We cannot cure emphysema, but we have all kinds of good inhalers. We cannot cure diabetes, but heck, we have insulin and metformin. We cannot cure mental illness, but we do have Prozac and we do have counseling. There goes the tooth fairy. Doctors save lives all the time. There's another myth. That happens in Hollywood and in ER shows like ER, St. Elsewhere, and Grey's Anatomy. That's where that happens. We occasionally save lives. For example, some occasional stab wounds, some car accidents. We save life with pacemakers, some overdoses. We save some certain obstetrical complications, and we can cure certain kinds of pneumonia. There goes the monster under the bed, another myth. Transplants are a cure. Well, they do, in many cases, add an additional release on life and do improve certain quality of life. But this is not like treating a hangnail, folks. These patients are all immunosuppressed with its complications, having immunosuppression. And of course, some people get organ rejections. They reject a kidney that they had, and they sometimes can reject a heart transplant as well. Let's debunk another myth that hospice and palliative care are equivalent to death panels. Some of you may have heard this several years ago. People spoke about death panels, and that hospice and palliative care means we're giving up on the patient. When in fact, palliative hospice care is compassionate care for patients and families who are suffering. Here's another myth, that having the conversation about end-of-life care, about having advanced directives, is taboo and will traumatize you and scar you for life. An absolute myth. En contraire, you'll find the very opposite to be true. Quick definition of what palliative care is and what it's not. It is not pulling the plug. It is not euthanasia, and it is not about death panels. It is about compassionate care for patients and families. It's about emphasis managing patients' symptoms, pain, breathlessness, nausea, anxiety, all miserable things that go along with end-of-life diseases. We want to eliminate those and treat those and make the patient as comfortable as possible. So we emphasize symptom management in palliative care. It's a beautiful thing. It's a team approach. It's just not one person. Palliative care teams consist of doctors, nurses, chaplains, social workers. It's a very multi-pronged approach to taking care of patients and their families. And it talks about goals of care. Very important. What are your wishes? What do you want? How can we best help you? And we respect the wishes of these patients and their families. It's a specialized medical care for people who have serious and life-limiting conditions. Clearly, this is not for someone with a sprained ankle or a bloody nose. This is for people who are facing serious life-limiting conditions. And it addresses the physical, intellectual, emotional, social, and spiritual needs. Isn't that beautiful? It's appropriate at any age. We even have in children's hospitals and at any stage in a serious illness, including people who are hoping for a cure, like certain forms of lymphoma, for example. And a very high percentage of patients in palliative care who don't get better smoothly transition into hospice care. You have a great hospice system in San Diego Hospice. There are many others, but this is one of the good ones you have in your location. It's a paid benefit. If your doctor says your prognosis is less than 6 months, Medicare will cover it. And the indications for palliative care are similar to those, for hospice care, similar to those for palliative care, but more in the late stages. I've often had palliative hospice people come to the ER with patients who are terminal, and invariably I hear the same thing. Gee, we wish we had referred the patient to us sooner. We could have done more. And all that takes is a phone call to hospice. They will come and interview and come and help you. A quick word about medical aid in dying, which is a discussion all in itself. You do have it in California. It's only legal in about 10 states, and many other states are working on it. It's kind of controversial. I certainly am at the very least neutral and for it. It's a totally separate discussion that we can have another time if you're interested. Now, this all may sound counterintuitive. However, I can tell you I'm not a maverick. I'm not a rogue. I'm not a renegade. And I'm not a dirty, rotten scoundrel. And I'm not a crook. I have the backing of the American College of Emergency Physicians and the AMA, who both are very much in favor of patients who need palliative and hospice care to receive it. These are data-proven benefits of hospice and palliative care. We improve symptoms, we improve quality of life, length of life, family satisfaction, better bereavement outcomes, less PTSD in family members. We match the care to the patient goals. We avoid unnecessary hospitalizations, unnecessary costs, and we maintain dignity. You know, there's some people who are ultimately just sick and tired of being sick and tired. I'll repeat that. Sick and tired of being sick and tired. And they may welcome an opportunity to have this conversation about goals of care. So, how about that conversation? If your doctor doesn't have a conversation with you, be your own advocate, be proactive. Set up an appointment to talk to your doctor about your loved one's prognosis and treatment options in someone who's not doing well. And become knowledgeable about invasive and life-altering treatment options, such as being on a ventilator, being on dialysis, getting a transplant, being oxygen dependent. Much of this information and education you can get, wait for it, on YouTube. Do your own diligence. You'll be glad you did. Speak to your family. Speak to your doctor. Speak to your lawyer, preferably an estate planning lawyer, and speak to your rabbi. Having the conversation may be awkward in the beginning. It may be uncomfortable, but I can guarantee you that you'll be glad you did. Here's some useful resources you can go to educate yourself. I love the Conversation Project. It's out of Boston, started by a woman named Ellen Goodman. There's another very good one out of Denver called Compassion and Choices. There's one here in Arizona called Thoughtful Life Conversations, and there are many more. You can Google them and get more information. If you want to look up how to do your own advance directives, in California, all you got to go is look up your Attorney General, Javier Becerra, type in medical power of attorney, and the forms will crop up. You can download them, you can fill them out, and then show them to your lawyer. It's not hard. Now, to make end-of-life and palliative hospice care more commonplace and less taboo, we need to change the culture a little bit, both in our world, meaning the medical world, and in the real world out there. Meaning we need more education and enlightenment. We need a willingness to accept and embrace that this is appropriate care in appropriate patients at the appropriate time, and that can be excellent, caring, and compassionate way of taking care of people. We have to also accept the fact that we're not giving up on the patient. For many people, dignified death is foreign to many people, and we as physicians still see losing the patient as a failure and the death as the enemy. And we are part of the problem, we in the medical community. Here in Arizona alone, I know of 2 palliative care doctors who worked at a cancer facility who were fired from their jobs because other specialists, especially the cancer doctors, the oncologists, complained that they were interfering with care. We have a problem in the medical community. I can tell you that much of why we struggle with this has to do with the inability to say goodbye. Even though, and I can tell you this without any doubt, that saying goodbye can indeed be the ultimate act of love. We know this with our beloved pets. I also encourage you to embrace your spirituality. It has been my experience, and I can give you many examples, that people who are connected to a higher power, whatever that higher power you perceive as, do better with end of life. I see that repeatedly. These are the rights of the dying. Dying people have rights. These are just some of them. They have a right to participate in decisions, the right to expect continuing care. They have a right to change their mind. They have a right to be free of pain. They have the rights of children to participate in death and to understand the breast process, and the right to die itself in peace and with dignity. I will tell you that primary care physicians don't do a very good job out there having end-of-life conversation with patients and their family, even though Medicare offers payment for this. As a result, we as ER doctors are often required to have that conversation with patients and families in a less than ideal and crisis situation. This is often with patients who are obviously near death, at death's door, or in a coma or in a semi-comatose state. Here's the example for you. A woman from a nursing home, she has dementia, she's 94, she has pneumonia, she's unresponsive, she's having her last breaths, and her two daughters are with her. This is a case that happened to me, and I've had many of these. One is on the one side of the bed saying, "Doctor, you got to save her. Do everything you can to save her." And the other daughter says, "You know, she told me she never wants to be on a ventilator or a respirator, and there are no advance directives." And then we have to make spot decisions in a very heated situation that is less than ideal to ensure dignified care. And it happens all the time. Many physicians are uncomfortable and poorly trained in having this conversation. And the medical community itself is guilty of giving patients and family false hope with life-limiting and serious illnesses. I find this to be intellectually dishonest and unacceptable. They may mean well, but it's not fair on the patients and families. However, I have some good news for you. There's ample opportunity to get better at this. Conflict management can be addressed. More good news. There are over 100 emergency physicians here in America who have either taken or completed a fellowship in palliative and hospice care, and the numbers are growing. We're becoming more proficient at it. Many hospitals have vibrant palliative care programs with regular family conferences. This includes patients who will be in the ICU for longer than 3 days. I know that at least 2 hospitals in San Diego have excellent palliative care programs ongoing. There are helpful catchphrases that physicians are taught. It seems to me that you or your dad or your mom are having a really difficult time and are suffering. Do you have a good understanding of your or his or her condition? How about we talk about it? What are your, his or her wishes? If you had your choice, would you prefer to go home rather than stay in the hospital? I ask that question all the time, and I'm amazed how often I get the response of, "Hey, doc, I'd rather go home. I don't want to be in the hospital." Or would you like more help to relieve your symptoms? Most people are going to say, "I would love that. I would appreciate that." What does dignity mean to me? Autonomy. Autonomy. Death on my own terms. Making peace by apologizing, asking for forgiveness, and repairing fractured relationships. People deserve and should have the opportunity to do this, and you can do this once you've had the conversation. I don't want to be a burden on my family and my loved ones, and I want to spend time being grateful for the wonderful life I've had. What does dignity mean to you? I'd like you to think about it. Quickly, a word about the COVID-19 pandemic. Came out of nowhere. It caught us off guard, caught us with our pants down. It created an unforeseen, unimaginable trail of devastation. Hundreds of thousands entering 2020-21 had no idea that it would be their last year on Earth. I worked for a while in the ICU during this COVID pandemic. I couldn't believe how many patients were on ventilators who would likely have said, "I don't want that because it's futile care." Many of them die on ventilators in the ICU, but they had no advance directives or conversation about their wishes. And this created an enormous and unprecedented burden on the need of ICU beds and ventilators. You've seen this in the news. Arizona was no different, and I'm sure neither was California. Utterly exhausted, fatigued, burned out doctors and nurses having trouble just staying afloat. And death crept up unexpectedly. This pandemic to me has been the most sobering reminder I've ever seen of the need to have your conversation and to have your advance directives in order. So this is the book. I also have a website at the blog that talks about other topics like planning, miracles, Yisker, and obituaries. Dr. Shapiro also has his own website called livesofmeaningful.com. And he can help with consultation on this. He can tell you more about it if you have questions, but it's a very well designed and excellent website for people who want to talk about end of life wishes and so on. Thank you so much for your time. And at this point, I hand it over to questions. I'm going to stop the share, and Dr. Shapiro and I will be available. So whoever would like to ask questions, please speak up so we can hear you. And we want to hear any questions, comments, or any storytelling that you might have.
I'd also like to just put a little bit of attention to the chat. We had a few people drop questions in there. Any of you that did drop a question in there that would like to read your question aloud, please feel free to unmute and do so. Well, just to address this, some people were asking how to watch this after this event. This will be on the Temple YouTube page.
Okay.
I'm all for everything that you said, but what struck me is your mother. So at what point, if you have Alzheimer's, at what point do you decide you want to die? I mean, you don't know how fast it'll go, how severe it'll be. To me, that is the ultimate dilemma. I'm all on board with the rest of it, but that's like, how do you handle that? I mean, you said with the crystal ball thing with your mother. I mean, what would you have done differently? I mean, how?
I wanted to make a comment on that. Okay, first of all, I want to emphasize something. Alan's talk is wonderful talk. One thing I do want to emphasize before I answer your question is that I always point out that it's the patient's decision, because usually, and Alan I think would agree, we wind up dealing with the family. So it's not a question of what you want or what your sister or brother wants. It's really a question of what mom wants or dad wants. I think that's terribly important to remember. We're doing, by not considering that, we're taking away the patient's autonomy. One suggestion as to what you're talking about, I'll let Alan comment too, is one of the things I like is to have a durable power of attorney. In other words, have somebody that you trust make the decision for you, especially in a case where you're talking about Alzheimer's, where you may not be able to make the decision. So you have, someone who you think is knowledgeable, who has your best interests at heart, and maybe has medical knowledge, and then they can make the decision when the time comes.
Risa, you asked a really good question there. I can tell you, there were times I would walk into my mother's, she was in a memory unit, what they called the Alzheimer's unit, that I so much would have liked to have picked up a pillow and put the pillow on her face. But in the state of Arizona, I don't know about California, that's called murder. I couldn't.
That's so true.
I would have pushed her over the cliff in a heartbeat. But hands are so tied in these type of situations, which is why, you see so much written about Alzheimer's and the tragedy and the impact it has on the patient and their families, and how, let me tell you this, you talk about relief. I remember coming back from my mother's funeral with my brother Ian sitting next to me. He's a cardiologist back east, just two of us in the car. And I took one look at him. We came back from the funeral and I said, is it just me? Or do you feel an enormous sense of relief? And he looked at me and he said, absolutely. So what I can tell you is when this horrible suffering ends, there's no question. Yes, you feel sadness that you've lost a loved one, but seeing immense suffering end invariably comes as a sense of relief to the surviving family. Great question, Risa, and I don't have a really good answer for that.
I have a question.
Sure.
Thank you.
Susan here. And I put it in the chat, and this is, I think, applies to most of us. I have an advance directive from our attorney. I think it's probably a boilerplate. I actually happened to read it just yesterday, maybe in, thinking about this program. But how specific should it be? Can it be? Can there be specific guidelines for stopping medical care and moving to palliative? Assuming that it's all been discussed with your next, your family who have power of attorney. How specific can it be?
I can quickly answer that and Bob can add. I mentioned this in the presentation. It actually is easier than you think. Once you are thinking along these lines, all it takes is a call to your local hospice or palliative care to come and discuss the situation with you. It's really much easier than you think. And they will go over, what can be offered, what the options are, what is palatable to you, what is unacceptable. And it just takes a phone call. Bob, you want to add to that?
Well, I'd like to add something. I think what you're saying is correct. It's impossible to prepare for every situation. As example, you have somebody has Alzheimer's, but they're not that bad, and they get pneumonia. Do you resuscitate or don't you resuscitate? That's why I think, my prejudice is to have somebody help you decide, and if you're not able to, if you have a condition where your competence is in question, that's why I think it's important to have somebody to make the decision for you.
There was another question I saw regarding how much pain medicine can be given, and by providers in the hospital care to possibly hasten death. That is a question that is frequently asked. I can tell you that this is best done by people who are skilled in hospice and palliative care. They have special training in how to give enough medication to make that person comfortable, free of pain, free of nausea, free of anxiety, free of shortness of breath. And yes, likely the additional medication given will shorten the time to death. But at the same time, that time will be peaceful. That time will be, we will rid of suffering, which is really, I look every single day at my desk, a beautiful writing by Moses Maimonides, who talks about, dear God, let me help your suffering children. And in medicine, we are truly obliged. If we cannot cure somebody, the very least we can do is help their suffering.
There's a thing called the law of dual effect, which is you are entitled to give a medication to relieve suffering, even though it may shorten a life. And that's been accepted by the Catholic Church. So there's no question that you can give as much morphine as is required.
We have a question here from Joan and Arnie Gass.
Yeah. So Alan and Robert, thank you very much for presenting this book. And Alan, thank you for your wonderfully illustrated talk. I'm a physician. I've done medical ethics. I'm an internist and geriatrician. So I'm on the other side. I loved ER work, but I went into it. I didn't go into it in part because I wanted to have longer term relationships with patients. So I see the patients who come out of your ER and come back to primary care. And a couple of comments I would have on here, as well as to answer one or two questions that are in the chat. First of all, in San Diego, we've adopted the term non-beneficial treatment. That's an alternative term to futile care. We regard care is always worth giving, but treatment is not. And so that's something that I have to keep reminding myself of all the time. Your mother and my mother must have been identical twins. And my mother was everything you said about your mother. She died 3 months short of her 95th birthday. My brother took care of her. I did her financial affairs. And when it came to cleaning her up, my sister-in-law, who was not a nurse, would not do it.
Who was a nurse?
Who was a nurse, but I did. And I felt that that was about the most humane thing I could do for her. So Rita Tarski put a question in the comment. What do we do if we think we might develop Alzheimer's disease? So in San Diego, we have a guy named Stan Terman. I don't know if you've heard of Stan, but if you haven't, you should. Stan and I were classmates at Brown University, and he's a psychiatrist in San Diego. And he has written a book, The Best Way to Say Goodbye, A Legal Peaceful Choice to the End of Life. And what he says that he has a 48-item matrix questionnaire, which enables you to put yourself on where you are on the spectrum of what you want to do. And then he will do a video recording of you when you still have the capacity to make decisions and tell people what you want. And when it comes time, your family can then exercise your wishes, not their wishes. And basically his point of no return is when you can't feed yourself, don't have anybody put food and fluid in front of you. Just have them use lemon swabs to the mouth to keep from getting mucositis. Anyway,
can you tell me again the name of that book and the author?
The Best Way to Say Goodbye by Stan Terman, Terman. And you can Google him, and he. This is one answer to your question, Risa.
Thank you so much. Very helpful.
And I can't wait to buy your book, Alan.
Oh, thank you so much for your input and your wisdom. This was, I wrote down what you just said over there, non-beneficial care. I love that conceptually. I think that is brilliant. Thank you so much for that.
It's actually non-beneficial treatment. That's the different word.
Got it. Fabulous. Thanks for your insight. That was awesome. Thank you.
Yeah, appreciate it. That's excellent. I'm going to read that book myself.
Who else would like to chime in? Who else? More questions on the chat, or would like to just add another story? We still have, it looks like, at least another 5 minutes or so.
One, I just wanted to give you Shapiro's law of the family, which is further away the sibling is from the care of the patient, the more they want everything done at the end. So the brother that lives in Pittsburgh that is not involved in the care of your mom who has Alzheimer's is the one who says do everything. Happens every time.
Yep. I can quickly tell the story of David quickly, if no one has any other questions. There's a friend of mine, his name isn't David, it's something else. A story about regretting heroic care. His mother was about 86, I believe, and she had what's called a thoracic aortic aneurysm, which is a pretty bad thing to have, but you can live with it for several years. What eventually does happen is it ruptures, and then you die very quickly with minimal suffering. You went and saw a thoracic surgeon locally who said, I cannot do this. She needs the operation. We need to send her out of state, which they did. They went to another state. They went to Houston, and she had pretty major surgery. She had a pretty rough course afterwards, but she survived the surgery, and she came back home to Phoenix, and she was never the same. She became frail. She was pretty robust. She became frail, forgetful. She took a hard hit. Anyway, she was back home for about 2 weeks. He would take her out to lunch 3 times a week. He knocked on her door. She'd been home 2 weeks back from Houston. No answer. He opened the door. There she was, deceased on the floor. And he spoke to me a few weeks later, and he said, I really, really regret putting my mother through this. She could have lived another 3 or 4 years. She was never the same. I wish we'd just taken a conservative approach. And he really took it hard that he was the one who convinced her to do it. And he felt guilty, and he felt really remorseful about it. So this happens commonly. So the conclusion is before you go forward with something that is really massively invasive in somebody who's who's 86 years old, do your due diligence first and maybe consider the more conservative approach so you can have a good quality of a couple of years rather than just 2 weeks. Anyone else with any comments or any questions? Well, we really appreciate this opportunity. Eileen, thank you so much for making this happen. And we're both very grateful that we can share some of our own personal stories. Dr. Shapiro says one of his, in the book, talks about some of his personal story and his personal life adventures, some of which are extremely personal, as to how he became involved in dignified end-of-life care as well. And
could you also share with everyone where they can get the book, the website?
Certainly. It's available on Amazon. As we just did, as I said, the second edition that became a #1 bestseller. And we also, you can get it on the website called savingdignity.com. Or you can get it on, as I said, on Amazon. And, we elaborate a fair amount we give real life examples of some really sad cases that could have been handled in a much more humane way. Often having to do with people unable to say goodbye, often have examples of how physicians were determined to keep people going in spite of there being significant suffering at end of life. And I can tell you, this is common. Physicians in certain specialties we see this in certain specialties even more, including oncology. I know that oncologists want to try and find all kinds of treatments for stage 4 cancer, but it's been our experience that some oncologists just don't know when to say it's enough or to actually offer the patient, you still want to keep going.
It looks like we may have one more question. Neil, did you have a closing question?
I just want to express appreciation for you guys discussing a subject that we've all been through. Thank you.
Our pleasure. Thank you.
Wonderful. I think that might be a perfect place to close. This has been fantastic. I know we do book for an hour, but we can stay on for just a couple more minutes. I will end the recording though. And I want to thank both doctors for being here with us today. I think we've been working on booking this for maybe a year. I feel like we started talking about this, in the middle of last year, and we said, all right, well, we've got virtual going, so we'll make it happen. But yeah, we do look forward. You did have that other topic you kind of dangled out there for a minute that you said you may be able to come and visit us another time with that other topic. So we look forward to it.